Welcome back to the Deep Dive. Today, we're opening up a topic that I think a lot of people, even those deeply embedded in the medical field, sometimes find a bit, intimidating.
It's dense.
It's dense, it's complicated, and the stakes are incredibly high. We are looking at the pelvic cavity.
It's often referred to as the black box of human anatomy. It's a space where multiple critical systems converge in a very tight, rigid area.
Exactly. And we're basing this discussion entirely on the chapter from Snell's Clinical Anatomy titled Pelvis, Part 2, Pelvic Cavity. Now, I want to be clear right off the bat, we aren't using chapter numbers because editions change, but the anatomy.
The anatomy stays the same.
That's the beauty of it. And before anyone tunes out thinking this is just going to be a list of Latin names and muscle attachments, I want to start with a story. This comes right from the beginning of our source material, and it's the perfect hook because it proves that knowing this geography is literally a matter of life and death.
It's a case study that really, it highlights the power of the physical exam. It involves a 62-year-old man.
Right. So picture this scenario. This guy walks into his physician's office. It's a standard annual physical. He looks healthy. He feels great. No complaints, no pain, no issues in the bathroom. By all accounts, he's the picture of health. The doctor goes through the general checkup: heart, lungs, reflexes. Everything is fine. And then we get to the part that, well, most patients dread.
The rectal examination, which, unsurprisingly, the patient tries to decline. He tells the doctor, look, I had one a year ago. Everything was normal. I feel fine. Let's skip it.
A very human reaction. Nobody wakes up excited for that.
Yeah.
But the physician insists, and thank goodness he did.
Yeah.
Because while performing that digital rectal exam, the doctor feels something, a small, hard nodule on the posterior surface of the prostate gland. It wasn't causing pain. It wasn't blocking urine. It was just there.
And because that doctor had a mental map of what normal feels like, what the consistency and texture of the prostate should be through the rectal wall, he knew that hard bump was a red flag. It didn't belong.
That persistence paid off. Subsequent tests showed elevated PSA levels. A biopsy confirmed early-stage prostate cancer. And because they caught it right then, before symptoms even appeared, they were able to remove the prostate.
And the prognosis was excellent?
It's just incredible. That is the thesis of our conversation today. This isn't about memorizing diagrams for a multiple-choice test. It's about that physician's finger. It's about having such a clear 3D visualization of the pelvis, this basin at the bottom of the torso, that you can navigate it blind.
You need to know what lies beneath the surface.
It's a high-density neighborhood. The text often refers to the pelvis as a crowded space. You have three major systems fighting for real estate inside a rigid bony ring that doesn't expand.
Exactly. You have the gastrointestinal tract, the urinary tract, and the reproductive organs. They are packed in tight, and they impact each other constantly.
So our mission today is to map this black box. We're going to break it down just like the text does into three distinct systems. We've got the plumbing, which is the GI tract. We've got the reservoir, which is the urinary system.
Right.
And we've got the generator, the reproductive organs, with a big focus on the prostate, since that's the star of our intro story.
And I must add a very important disclaimer here. What we're doing today is an interpretation of the chapter. Think of this deep dive as a ready reckoner or a companion guide to help you visualize these concepts.
Right.
It is not a replacement for reading the text.
Absolutely not. Reading is becoming a lost art. And we're kind of on a mission to bring it back. We want you to listen to this, get the concepts locked in, have those aha moments, and then this is the call to action. Go open Snell's Clinical Anatomy.
Please do.
You need to see the diagrams we're talking about. We can give you the map, but you have to watch the territory.
Especially when we get to the vascular systems later. You need to see those connections to believe them.
So are you ready to dive into the plumbing?
Let's begin with the gastrointestinal tract. Specifically, we're looking at the sigmoid colon and the rectum.
Okay, the sigmoid colon. The text describes this as a mobile loop. I always picture it as this, loose S shape hanging down into the pelvic cavity.
That S shape is where it gets its name sigma. It's about 10 to 15 inches long, connecting the descending colon to the rectum. But the characteristic you hit on, mobility, is the most critical clinical feature. Unlike the descending colon, which is stuck to the back wall, the sigmoid hangs on a fan-shaped fold of peritoneum called the sigmoid mesocolon.
And in the medical world, mobile usually means can get into trouble, right?
It does.
If it can move, it can twist.
Precisely. Because it hangs freely, it is prone to twisting around its own blood supply. Imagine a garden hose that loops over itself. If the sigmoid colon rotates around its mesentery, usually in a counterclockwise direction, it kinks the artery feeding it.
And that condition is called?
Volvulus. It creates a complete obstruction. The loop fills with gas and fluid, and because the blood supply is cut off, the tissue starts to die. Ischemia?
Ischemia, exactly. It requires urgent correction, or you're looking at gangrene and perforation.
So the very thing that defines it, its mobility, is its Achilles heel. Now, the source material also spends a significant amount of time talking about scoping this area as sigmoidoscopy. It sounds like navigating a submarine through a cave system. What's the big danger zone here?
It's the junction between the rectum and the sigmoid colon. Anatomically, this isn't a straight shot. There is an acute angulation. The rectum comes up following the sacrum, and then the sigmoid bends sharply forward and to the left.
So let's create a scenario here. You're a junior doctor, maybe a bit tired pushing the endoscope in. You're in the rectum, moving up, and you hit resistance if you just keep pushing straight.
You're going to perforate the bowel wall. You're pushing the stiff instrument right through the tissue. You have to negotiate that curve, steer the scope anteriorly and to the left to enter the sigmoid lumen safely. And here's a fascinating detail from the text regarding pain. If a patient is awake during this, or lightly sedated, and the doctor negotiates that bend clumsily, where does the patient feel it? You'd assume they feel it in their rectum, wouldn't you?
You would, but you'd be wrong. They feel colicky pain near the umbilicus.
The belly button.
The belly button. It's that weird referred pain wiring we see in the gut.
How did that work?
The sensory nerves from the sigmoid colon enter the spinal cord at a much higher level, corresponding to the skin around the navel. So pain in the belly button can actually mean the scope is stretching the sigmoid colon way down in the pelvis. That's a key diagnostic clue.
That's a great clinical pearl. So we make the turn, and now we're in the rectum. Now, despite the name rectum sounding like rectus, which implies straight, it's actually not straight at all, is it?
No, it's a total misnomer. The rectum follows the concavity of the sacrum. So if you look from the side, it has a significant curve. And inside, it isn't a smooth tube either. It has these 3 permanent transverse folds.
The valves of Houston.
The valves of Houston.
It sounds like a rock band playing a dive bar in Texas. Ladies and gentlemen, please welcome the valves of Houston.
I suppose it does, but they have a very practical function. They act sort of like shelves. They help support the weight of the fecal matter. If the rectum were just a straight, vertical, smooth chute, the weight of the column of feces would press constantly against the anal sphincter.
You'd feel a constant urge to go, like you're always on the verge of an accident.
Exactly. These valves break up that column of weight, allowing the rectum to act as a storage reservoir without constant urgency. It allows us to be socially functional human beings.
That is surprisingly thoughtful of evolution. Now, we need to move to a concept that I think trips up a lot of students, but the text highlights it as vital for trauma medicine. The relationship between the rectum and the peritoneum.
The rule of thirds. This is essential. The peritoneum is the membrane lining the abdominal cavity, the sac that holds your guts. But it doesn't cover the rectum evenly. You have to visualize the rectum divided into 3 segments: upper, middle, and lower.
Okay, walk us through the coverage.
The upper third is covered by peritoneum on the front and the sides. It's fairly exposed to the abdominal cavity. The middle third is covered only on the front. And the lower third, it's completely naked, no peritoneum at all.
Okay.
It sits below the peritoneal floor.
So let's apply this. Why does this matter? Let's say someone comes into the ER with a penetrating injury, a knife wound, or a bullet. That hits the rectum.
It changes the entire surgical approach and the risk profile. If the injury is in the upper third, the bullet pierces the peritoneum. That means fecal matter and bacteria spill directly into the main abdominal cavity.
Into the peritoneal sac.
Right. And that causes peritonitis, which is a massive, life-threatening whole belly infection.
But if it hits the lower third?
It's an extraperitoneal injury. The hole is effectively outside the main abdominal cavity. The infection and leakage stay trapped in the dense tissues of the pelvis, usually in the space right in front of the sacrum.
So it's contained.
It's contained. It's still a serious infection, but it won't cause generalized peritonitis. The containment is different, so the treatment is different.
That's a huge distinction based on just a couple of inches of anatomy.
Yeah.
1 inch higher, you have peritonitis. 1 inch lower, you have a localized pelvic abscess.
Exactly. Understanding that boundary is key.
Okay, let's move to the blood supply. The rectum seems to have a lot of backup systems.
It does. It's very well vascularized. It has a triple supply. The superior rectal artery coming from the gut system, the middle from the pelvic system, and the inferior from the perineal system.
Hmm.
But the veins are where it gets really interesting clinically.
Hmm.
We have what's called a portal systemic anastomosis.
Okay, let's unpack this.
Yeah.
This is a classic medical school concept, but let's make it clear for everyone. We have two major drainage systems in the body, right? The systemic, which goes to the heart via the vena cava,
Right.
and the portal, which goes to the liver.
Correct. So the superior rectal vein drains up into the portal system to the liver. The middle and inferior veins drain down and out into the systemic system. The rectum is one of the few places where these two watersheds meet.
So imagine a patient with liver disease like cirrhosis. Their liver is scarred and hard. The blood trying to get through the liver hits a wall.
It's a traffic jam. The blood acts like water in a blocked river. It backs up, it looks for an escape route, it flows backwards down the portal system to find a way to the systemic circulation.
And it finds that connection in the rectum.
It finds that connection, and it blows out the veins. These connecting veins become engorged and twisted with high-pressure blood. That swelling is what we know as internal hemorrhoids.
So hemorrhoids aren't just a local annoyance. In some cases, they can be a sign of significant liver pathology.
Exactly. It's a pressure valve problem.
That connects the plumbing to the liver in a way you don't usually think about. One last thing on the gut before we move on. Cancer spread. The text mentions that lymphatic drainage follows the arteries.
Right. This is crucial for cancer surgery. If you have a tumor in the upper rectum, the lymph fluid and any cancer cells floating in it drains upwards along the superior rectal vessels.
So if you are the surgeon, you can't just cut out the tumor and stitch it.
No, you have to remove the gut, but you also have to chase that lymphatic chain way up into the abdomen to ensure you catch any metastases that are migrating north. It's like weeding a garden. If you leave the roots, the lymph nodes, it comes back.
Okay, before we leave the plumbing, I want to do a check-in question. This is for you, the listener.
Yeah.
I want you to actively think about this.
This brings us back to the intro.
If you are performing that digital rectal exam we talked about, and you are examining a male patient, what structure lies directly anterior to your finger? Pause the audio if you need a second. Visualize the finger and the rectum facing forward. What are you touching?
And the answer is the prostate gland and the base of the bladder. If you didn't get that, you might want to rewind to the story at the start. It's the most important clinical relation in this chapter.
All right, let's move to part 2. The reservoir. The urinary tract. We're talking ureters and bladder.
Let's start with the ureters. These are the muscular tubes carrying urine from the kidneys down to the bladder. The text uses a very helpful relationship anchor here. Water under the bridge.
I love this metaphor. It helps visualize the 3D crossing of tubes in the pelvis. The water is the urine in the ureter. What is the bridge?
It depends on the sex, and this is high yield for surgeons. In males, the bridge is the vas deferens. It crosses over the top of the ureter.
Okay.
But in females, the bridge is the uterine artery.
This is the famous danger zone in gynecological surgery, isn't it? Let's create a fictional case here. Dr. Smith is performing a difficult hysterectomy. There's a lot of bleeding. Visibility is poor. He needs to clamp the uterine artery to stop the blood flow to the uterus.
And that is the moment of truth. The ureter runs directly beneath that artery, sometimes just millimeters away. Water under the bridge. If Dr. Smith isn't careful or doesn't have that anatomy clear in his head, he clamps the bridge.
And the water at the same time.
And the water at the same time. He ties off the patient's ureter.
Which means the Kyrie is now pumping urine against a closed door.
Exactly. It's a catastrophic complication that can lead to kidney loss. Water under the bridge. Remember that phrase?
Now, kidney stones, they don't just get stuck anywhere. The text says they get stuck in specific narrow spots.
Right. The ureter isn't a uniform tube. It has 3 anatomical constrictions. The first is where the ureter leaves the pelviureteric junction. The second is where it crosses the pelvic brim, that bony ridge entering the pelvis. And the third, and most common for impaction, is where it actually tunnels into the bladder wall.
So if a patient is writhing in pain, the stone is likely lodged at one of those 3 toll booths.
Pretty much.
Let's talk about the bladder itself. I was surprised to learn from the text that it's a bit of a shapeshifter.
It is very dynamic. When it's empty, the bladder is pyramidal in shape, and it hides safely behind the pubic bone. It is a true pelvic organ, protected by the skeleton. You can't feel an empty bladder through the stomach wall, But when it fills up,
It rises.
it becomes ovoid and rises up out of the pelvis and into the abdomen. It can reach all the way up to the umbilicus if it's really full.
And there's a really cool clinical trick associated with this rising, right?
Mm-hmm.
It involves the peritoneum again.
Yes. As the bladder fills and rises, it peels the peritoneum off the anterior abdominal wall. It pushes the lining up.
Why is that useful? Let's go back to the ER.
Imagine a patient has acute urinary retention. Maybe a stricture, maybe a blocked prostate. They simply cannot pee. A catheter won't go in. The bladder is bursting, painful, ready to rupture.
A nightmare scenario.
It is. Because the full bladder has peeled the peritoneum away, a physician can insert a needle directly above the pubic bone. The needle goes through the skin, muscle, and straight into the bladder without ever entering the peritoneal cavity.
So you don't risk puncturing the gut or causing peritonitis.
Exactly. It's called suprapubic aspiration. You drain the urine safely because the anatomy created a safe window for you. The full bladder effectively pushes the danger out of the way.
That is brilliant design. Now let's look inside the bladder. We have the trigone. It sounds like a geometry problem.
It's a specific triangular area at the base of the bladder. The top two corners are where the ureters enter. The bottom corner is the urethra exit. What's unique is the texture. While the rest of the bladder is rugged and has fulgurae that allow it to expand, the trigone is always smooth.
It acts like a funnel.
Exactly. The mucosa is tightly adherent to the muscle there, and the ureters enter the bladder wall at an oblique angle here. This creates a natural passive valve.
How does that work?
Think about the pressure. As the bladder fills with urine, the internal pressure rises. That pressure presses against the bladder wall. Because the ureters run through the wall at an angle, that pressure flattens the ureter shut.
So the fuller the bladder gets, the tighter the door closes.
Correct. It prevents urine from backing up, refluxing into the kidneys, which would cause infection and damage. It's a mechanical valve, no electricity required.
Which brings us to the electricity, the wiring diagram, the neurology of micturition, or in plain English, peeing. This seems complex, but let's break it down.
It's a reflex loop, but we can simplify it. Stretch receptors in the bladder wall say, "We're full." That signal goes to the spinal cord, specifically levels S2, S3, and S4. The parasympathetic nerves fire back, telling the bladder muscle, the detrusor to contract, and the sphincter to relax.
Yeah.
And you pee.
But obviously, we don't just wet ourselves every time the bladder stretches. We have a brain involved.
Hopefully. The brain sends inhibitory signals down the spinal cord to block that reflex until you are in a socially appropriate location. It effectively says, not yet, hold it.
Right.
But spinal cord injuries can break this loop in different ways. The text outlines 3 distinct scenarios that are really important to distinguish.
Okay, let's run through them with case studies. Scenario A, a patient has just been in a severe car accident with spinal trauma. Immediate injury, spinal shock.
This is the atonic bladder. Right after a severe injury, the nervous system goes into shock. The bladder muscle completely relaxes. It loses its tone. But the sphincter stays tight. The bladder just blows up like a balloon until it physically overflows.
So the patient isn't peeing, they're just leaking because they are full to the brim.
Exactly. It's passive overflow. They have no control and no reflex.
Scenario B, the automatic reflex bladder. This is when the injury is above the sacral level, maybe in the thoracic spine, and some time has passed since the accident.
Right, so the connection to the brain is cut, no voluntary control. The brain can't say hold it. But the local loop at the bottom of the spine, S2, S4, is intact and functioning. The bladder fills, the stretch reflex fires, and it empties. Automatically, just like a baby.
The patient can't stop it or start it, it just happens when full.
Exactly. It is a functioning reflex, but uninhibited by the brain.
And finally, scenario C, the eponymous bladder. This sounds the worst.
This is when the injury destroys the sacral center itself. S2, S3, S4 are gone. Maybe a tumor or trauma to the cauda equina. The reflex loop is destroyed. The bladder wall is flaccid. It doesn't squeeze.
So it just fills and dribbles.
Fills and dribbles, fills and dribbles. Because it never squeezes, it never really empties, so there is always residual urine.
And stagnant pools of water are breeding grounds for bacteria.
High infection risk, yes. It's a stark reminder of how complex the simple act of using the bathroom really is.
Let's do another quick check-in here before we move on. Listener, pause and think. What are the 3 locations a kidney stone is most likely to get stuck?
If you set the pelvureteric junction, the pelvic brim, and the entrance to the bladder, you're spot on. If not, go back and listen to the toll booth section again.
Okay, let's move to part 3. The generator. The male internal genital organs. The text covers the vas deferens and seminal vesicles, but the heavyweight champion here is the prostate.
We should touch on the vas deferens briefly, though. It's a thick-walled tube about 18 inches long. It carries sperm from the testicle to the urethra.
And it joins with the duct of the seminal vesicle to form the ejaculatory duct,
Which runs right through the middle of the prostate.
Let's talk about the prostate. It's the guardian of the gate.
It surrounds the urethra just below the bladder. It's about the size of a walnut. Its job is to squeeze an alkaline secretion into the urethra to neutralize the acidic environment of the vagina, ensuring sperm survival.
But anatomically, the text breaks it down into lobes. And this is where it gets really interesting for diagnosis. We have anterior, median, posterior, and lateral lobes.
And knowing which lobe causes which problem is the key. We had a showdown here. BPH versus cancer. These are the two most common prostate conditions, and they affect different lobes.
Let's start with BPH, benign prostatic hypertrophy. This is the enlargement that happens to a lot of older men. Which lobe is the culprit?
The median lobe. This lobe sits right up against the bladder neck, deep inside. When it grows, it pushes upward into the bladder. It acts like a ball valve.
So when the patient tries to push to pee,
The pressure actually forces this lobe over the opening, blocking the flow. It's paradoxical. The harder they push, the harder it is to go. The text mentions this causes swelling of the uvula vesicae, a ridge inside the bladder. A pool of stagnant urine forms behind this dam.
and again, stagnant water equals.
Infection, cystitis. So BPH is a plumbing problem caused by the median lobe going up.
What about prostate cancer?
Cancer often starts in the posterior lobe. This is the part of the gland that lies directly against the anterior wall of the rectum.
And bringing it full circle to our intro story, that is why the doctor could feel it.
Exactly. The posterior lobe is accessible to the finger. A hard nodule there is palpable through the rectal wall. If the cancer started in the median lobe deep inside, you wouldn't feel it till it was huge. That's why the exam works.
Now, there is a terrifying bit of anatomy in the text about how prostate cancer spreads. It involves something called the prostatic venous plexus.
This is critical to understand. The veins around the prostate are valveless.
Valveless.
And they connect directly to the vertebral veins, the veins inside the spinal column.
Valveless means blood can flow in either direction depending on pressure.
Correct. Nature didn't put check valves there. So imagine a patient with prostate cancer. He coughs or sneezes or strains to lift something heavy. The pressure in the abdomen spikes.
And the blood looks for an exit.
That pressure pushes blood backwards out of the prostate and directly into the veins of the spine. This system is sometimes called Batson's plexus.
Carrying cancer cells with it.
Exactly. It's a superhighway for metastasis. This is why prostate cancer so frequently spreads to the pelvic bones and the lower vertebrae. It rides this valveless current straight to the bone.
That is vivid and horrifying. But it explains why back pain can be such an ominous sign in these patients.
Yes. If an older man presents with urinary symptoms and new deep back pain, you have to worry about metastasis to the spine via this exact route. It's not just a backache, it's anatomy in action.
Let's shift gears to part 4, embryology. The why behind the layout. It all starts with a single room, right?
The cloaca. In the early embryo, we don't have separate exits for liquid and solid waste. It's just one chamber. Then, a wall called the urorectal septum grows down the middle.
Dividing the house into a front room and a back room.
The front room becomes the bladder and urogenital sinus. The back room becomes the rectum and anal canal.
But sometimes this remodeling goes wrong. The text highlights a couple of anomalies.
One is ectopia vesicae, or exstrophy of the bladder. This is a failure of the mesenchyme, the connective tissue, to migrate and close the lower abdominal wall.
So the bladder is outside.
It's open to the outside world. The anterior wall of the bladder is missing and it projects through the abdomen. It requires complex surgical reconstruction.
And the other one is Hirschsprung disease, or megacolon. It sounds massive.
It looks massive on an x-ray, but the problem is actually microscopic. It's a nervous system failure. The parasympathetic ganglion cells, the nerve cells that tell the bowel to relax and allow things to pass, fail to migrate to a specific segment of the bowel, usually the rectum or sigmoid.
So that segment stays permanently clamped shut.
Constricted, yes. It can't relax. So the normal bowel above it keeps pushing and pushing against this blockage. It balloons out, becoming massive, hence megacolon.
Wow.
The irony is that the huge part of the bowel is the healthy part trying to do its job. The skinny part is the sick part. The treatment is to surgically remove the segment that doesn't have the nerve cells.
It's amazing how these tiny developmental steps have such huge consequences. We're coming to the end of our deep dive, so let's try to synthesize this. We keep coming back to the digital rectal exam.
It really is the clinical anchor of this chapter. We talked about the prostate, but think about the anatomy we've covered. In a male, anteriorly, you feel the prostate, the seminal vesicles, and the base of the bladder.
And in a female.
You feel the vagina and the cervix. In fact, the text mentions a clinical pearl, checking the rectovaginal septum by placing one finger in the rectum and one in the vagina. It allows a pincer-like examination of that tissue to check for thickening or tumors.
And posteriorly, for everyone, you feel the sacrum and coccyx. It's a lot of information from one finger.
It is, and for the listener, the so what here is that anatomy is dynamic. In the books, it's static. But in life, the bladder fills and rises, the rectum curves and holds weight. The sigmoid twists, the prostate grows.
Understanding those relationships, knowing what is next to what, is the difference between a successful surgery and a catastrophe.
Yes.
Is knowing not to cut the ureter when you're aiming for the uterine artery.
Exactly. It's about respect for the territory.
I want to end with a provocative thought that jumped out at me from the text. We touched on the neurology of the bladder sympathetic versus parasympathetic.
Yes, the classic teaching.
The textbook says, sympathetic holds it in, parasympathetic lets it out. But Snell throws in a little doubt, doesn't he?
He does. He notes that while that is the traditional model, the sympathetic nerves might actually have very little to do with the bladder muscle itself in humans. Their main role might be vascular controlling blood flow, or specifically in males, preventing semen from flowing backward into the bladder during ejaculation.
So the clean wiring diagram we learn in school might be a simplification.
It often is. The reality of clinical medicine, especially when treating incontinence, is often messier than the charts suggest. It's a reminder to always question and look deeper.
I love that. The map is not the territory. Well, speaking of the map, we have given you the overview, but you need to see the terrain.
Go open that chapter in Snell's Clinical Anatomy. Look at the diagram of the prostatic venous plexus. Look at the peritoneal reflections. Make this mental map real.
Thank you for joining us on this tour of the pelvic cavity. Stay curious and keep digging deep.
Until next time.